First of all, I would like to thank you all for joining. And this is a part of our desire to help endoscopy fellows. And our topic is endoscopy, occupational injuries, starting out right from the get-go. And this is actually Zoom class number 9. And I'm delighted to have Selvi Tirumurthy. Selvi is our Director of Education at MD Anderson, and Minaz Shafi. Minaz is a Professor of Medicine at MD Anderson and a Deputy Division Chief in our group. And she is interested in motility, and she's also interested in occupational injuries. And also, I'm delighted to have Amandeep Shargal. Amandeep is currently is on faculty at UCSF, Professor of Medicine, and she did original work in this area. Her master's thesis was occupational injuries in endoscopists, and she has written a lot, and she has produced a beautiful DVD for ASCE. So I'm delighted to have my favorite people on the panel, and these are my acknowledgements. I think whenever you're doing any work, it's because of support from several people. John Stoline for his support, Mr. Charles Butt and H.E.B. Grant, Ms. Angela Deal. Angela is a medical illustrator, and she has drawn all the diagrams that you're going to see here. And Suresh, Sanji Suresh, who is an educator. She has been working closely with me to develop endoscopy tech training program course material that we are going to start next year at the Houston Community College. And Sanji is planning to go to medical school next year. So these are the objectives. And what I would like to go through is give you, especially for the fellows who are starting endoscopy, they need to know what is ahead of them because they have taken a career path that is different from being a physician. And it is important for them to know some of these important aspects of being an endoscopy. So I'm going to cover how many of us will suffer in terms of injuries, and why do we suffer, and what is the secret behind what happens in endoscopy, and how do you keep yourself from getting injuries, and a little bit about basic movements in endoscopy. And if you learn the basic movements in endoscopy principles, you'll be able to avoid injuries. And then finally, how do you run your show to keep yourself safe? And then after that, we will have a panel discussion. For the sake of, if you have any questions, please send as a chat. And at the end, we will have an open discussion. And Selvi will look at the chat and ask the question and open up the unmute people who want to ask a question. I hope this works. So if you say to yourself, you enter the endoscopist as a first-year fellow, there's a lot to learn. And in your interview, you may be saying this, right? I love endoscopy, and I have great hand-eye coordination. I love doing things with my hands. That's why I want to become an endoscopist. And when you enter endoscopy, one of the goals you may have is, can I scope for the next 30 years, right? You finish your fellowship by mid-30s, and you should be able to practice at least until mid-60s, or if not later. So if you say to yourself, how do I practice endoscopy for the next 30 years? It is important for you to keep yourself in good shape so that you can offer your services. As you age, you become better because you have learned from your mistakes. So how do you keep yourself in shape so that you can provide service for a long time? I want to make sure that I share this information. This is Amandeep Shorgal. Amandeep produced this beautiful DVD for ASGE. And as part of your learning, take time to spend at least reviewing this video a couple of times so that you learn the basics of how to prevent injuries. And that's the most important thing. It's not about just learning endoscopy. How do you do it so that you can run your show for the long time? So let me take a step back. And if you ask yourself, how many of us will suffer in terms of endoscopy related injuries? If you look at it, about 1 in 4 will develop eventually issues with their neck and shoulders to the point that they may seek medical attention, and some of them may even have to take time off, and some of them may even end up having surgery. So something to keep in mind. And if you look at hand injuries, it is 1 in 3, much more frequent. And this could actually end somebody's career. So injuries are common, and injuries can make somebody retire from their job. So when you look at the question, why do we suffer? What's the reason behind that? And two things. There is a transition point now when you become a first-year GI fellow. You're not just a physician, but you are going to become an endoscopist. And as part of the endoscopy, you will be performing a lot of manual work. I mean to say manual work with the endoscope. And that is what is going to make you not only become an endoscopist, but will be facing the risks associated with endoscopy in terms of injuries that can happen. So let us look at what is the underlying mechanism. So say, for example, you're doing in the first week or 2 weeks or 3 weeks, you're doing endoscopy every day, and then you are not focusing on several different things that we're going to talk about. You may start developing an injury, and the injury leads to inflammation, and the next day you come back to work. You don't take a break because you're so excited, and then more injury, more inflammation, and the cycle continues. And as this goes on, over a period of years, the cycle could lead to degenerative joint disease. And once you develop a degenerative joint disease, it is not reversible anymore. So as you are doing endoscopy, what happens is towards the end of the day, you may have a little bit of an ache, and you may say, I'm going to take a little bit of Tylenol, go to bed. Next day morning, you come back, you do the same endoscopy, and you continue. And the ache becomes not only in the daytime, but also nighttime, 24 hours a day. When you have that problem of ache, not just daytime, but day and night, that means you are at the verge of having a degenerative joint disease. This is very important. When you are doing endoscopy and you have aches and pains, you should not ignore. And those who ignore can develop severe disability, and to the point of taking time off. And some of them may have to give up endoscopy. So you don't want to do that, because by the time you become very good, if these injuries catch up with you, you are no good because you cannot do the procedure. So what is the big thing that will help you? Not only doing endoscopy properly so that you could prevent injury and inflammation, but taking rest. Rest is really critical. And I want to stress this again and again because rest allows your body to recover. And those rests could be in different forms. And I would like to comment on that as we get there. So the key is whether you're taking rest. If you do not take rest and you do not listen to your body, you're for sure going to retire prematurely. And once you retire as an endoscopist, by the time you retire as an endoscopist, you may have lost all the other skills of being a physician. You may not even know how to treat hypertension or diabetes. You may not even know how to treat IBD or liver disease, and you're basically gone. So it is very important to keep this thing in mind and take care of your body properly so that you could enjoy doing endoscopy and serving a lot of people as you develop a lot more experience as you age. So what is the secret? Taking rest. And you may think it is simple, but this is the most difficult thing to do because we are all driven to do a lot and a lot more in a shorter period of time and not taking care of ourselves. So taking rest is really critical. So let me take a few steps back, and this is for the sake of first year fellows, basic movements, and I want to take hand as an example, a neutral position of the hand, right? That is the most powerful position, and you'll have less strain when you have a neutral position of your hand. But in different times during endoscopy, you may need to either supinate or pronate, and these are extreme movements on the hand. And then coming back from the neutral position, you may extend the hand or flex the hand, again in a different dimension. And finally, coming back to neutral position, you can have abduction or adduction. And sometimes you may be using a pronation with flexion and adduction, making it a very extreme movement. Extreme movements practiced for a long time set you up for injuries. And the same repetitive movements of extreme movements are the ones that cause damage. So you have to keep in mind as you're doing endoscopy to have that feedback, to listen to your body and say, am I in my extreme movement of my hand? And could I avoid this? Or could I do it for a very short time rather than for a prolonged time? If you hear your body and make adjustments, you will come out safer for the long haul. So extreme movements can ruin careers prematurely. And this is an important aspect that we should all keep in mind as a first-year endoscopist trying to learn endoscopy or a first-year therapeutic endoscopist trying to learn complicated endoscopy. And we should not forget as faculty when we start our careers. So let's talk about how do you run your show to keep yourself safe. So there are basically 3 S's. Your schedule, your scope, and yourself. The only thing that you would control is yourself, that we're going to talk about it a little later. But where you work determines your schedule, because your schedule may be not in your hands. Somebody decides that this is the amount of work you're going to do, this is the number of cases you're going to do, this is the amount of break you're going to get. All that could be determined by somebody else. So you have to keep that thing in mind when you take up a job about what your schedule is going to be. And the second thing is you also need to keep in mind about the structure of your scopes in terms of whether they are well maintained or not. And finally, how do you maintain yourself? So let us talk about that. So let's focus on schedule. So you have Monday to Friday, 5 days a week. Some places work 6 days a week. And for somebody who just graduates from endoscopy may be so excited that they want to do endoscopy every single day. And when you do this every single day, without a break in between endoscopy schedules, this is what is going to happen. You are likely to develop injuries, especially if you're not practicing proper techniques of endoscopy. You're going to develop inflammation, and the cycle goes on, and you are going to be prematurely out of your job as an endoscopist. And with COVID, some of us are doing endoscopies to catch up for the last days of time when we are shut down, and this is not a good idea. What should be an ideal endoscopy schedule? And if you look at it, an ideal endoscopy schedule should be, you have every other day, you should have a break period. And if you're doing the whole day, you should have a break period in between. Missing these break periods and doing it for a few weeks in a stretch could put somebody at risk for injuries. So something to keep in mind, and every endoscopy director or administrator should keep this thing in mind, to have their endoscopy crew work for the long haul successfully and not break them down by giving them a very hectic schedule. It may not mean much if somebody is catching up to do cases, but to lose an endoscopist, you have to wait for another 35 years to make another endoscopist. You have to know that. You know, endoscopists are not made out of a bucket. You know, they have to go to med school, they have to do residency, they have to do GI fellowship, and then come out. And even then, they're very green, so it takes a long time. So you want to preserve your endoscopists so that they can help you for the long haul. So I want to reinforce this concept of taking a break between days, and then taking a break during the day, and also like Minaj taught me about taking so-called mini breaks or micro breaks. I would ask Minaj to comment on this at the end so that you can hear her thoughts about how she manages her day. So next is scope. And if you look at it, there are two things in a scope. One is the bending section of the scope, and the second one is the control section of the scope. If the bending section of a scope doesn't bend, like instead of bending like this, it is not bending. So what will happen is you will compensate by extreme movements of your body. And that's why maintaining the scopes in good order is very important, so that the endoscopist doesn't have to compensate for a scope that is not working well. The other thing is, there are two wires or four angulation wires that go from the dials, and they have to be set at a particular amount of resistance. And if there is too much resistance, you will be injuring your thumb. If there is too little of a resistance and the wires are too loose, you will have to compensate by other movements, which may be extreme movements and cause damage to you. So your endoscopy unit has an obligation to make sure that the scopes are in good shape and the angulation wires are also in good shape, so that you can run your show for a long time. So now coming back to what you should do from as you're managing your own self. So let us talk about it in a little more detail. And because this is totally new for first year fellows, please bear with me because I want to repeat certain concepts again and again so that you could appreciate the importance of every single thing that I'm going to talk about. So here is an endoscopy unit. You enter the endoscopy unit and you can see that you're excited to do the endoscopy. And you divide the endoscopy unit into 3 different buckets. And one bucket is yourself, how do you manage yourself? Second bucket is the patient, the bed and the monitor. And the third bucket is the processor. So as you can see this, in each of the buckets, there are several different items that you could control to make your endoscopy experience enjoyable and less prone for injuries. So let us talk about every aspect of endoscopy that you need to take into consideration to prevent injuries. So let's talk about the patient and the bed and the monitor. So here is an endoscopist trying to do the scope. The technician has not lifted the bed, and the endoscopist is in a rush. He wants to not waste any time to lift the bed, and the bed is too low. And when the bed is too low, you are going to bend forwards and you're going to strain your back. So the most important thing is to lift the bed. And to lift the bed, how far should you lift the bed? As you can see here, there is a measurement that you need to get. But most important thing is you look at your hand, and if your hand is just about 90 degrees or less than 90 degrees, a few degrees less, that is the most comfortable position. And that's how far you need to lift the bed. So that is very important. First thing is check whether the bed position is optimum for you or for your height. If there is a unit where you don't have beds that can be moved up and down, and there are few people working, then it makes sense to have the beds suitable for a particular endoscopist and let that endoscopist go to that particular room instead of going to a room that has a high bed or a low bed that puts him at risk for injuries. And I'm making this comment because I'm also talking about places where they may not have resources to have adjustable beds. The next one is monitor. And here is a monitor that is too high, and then you're extending your neck, and extending the neck could cause issues with the cervical spondylosis, cervical disc disease, cervical myelopathy because of disc prolapse. So you want to keep the monitor at or just below the eye level so that you're comfortable watching the screen. And this is very important to do. So as you can see here, this is an incorrect position. The monitor is high. The neck is a little bit extended. Here the neck is in line with the body and is just below the eye level. So as you can see that. So this is helpful if you have a monitor that you could adjust up or down. But you may not have a monitor that adjusts up or down. You have a monitor fixed to the wall. And if that's the case, you want to keep in mind the endoscopist's height and assign them to a particular room so that they can be comfortable without having to strain their neck. So something to keep in mind. The next thing is monitor position. You want to have the monitor position directly in front of your eyes, right? That is the most important thing. You don't have to bend your neck, turn your neck, or do anything. And sometimes what happens is the patient is in the left lateral position. You may have to put them on a supine position, especially for a peg, But PEGs are not long duration procedures. But putting a patient in a supine position usually happens in a ERCP room when somebody is trying to work in the hilum of the liver, when you want to see the right and left branches of the hepatic duct nicely. And when you do that, that is going to be a very long procedure, especially if there are strictures you need to dilate and you're going to strain your neck. So when the patient is supine, you're going to have a crooked neck trying to look to the left. And it's important in those cases to avoid that stress on your body by moving. Sorry about that. So by moving the screen right in front of you, and even if it is for a short while, make it a habit to make sure that your head is straight and you're able to see the monitor straight without moving your head to the right or left or having a crooked position. So now let's look at about positioning your processor. One of the first things that I do when I go into my room, because we have several endoscopists, every endoscopist has a different preference. So the monitor could be moved around from a case that was done yesterday or the day before. So what I do is, the first thing I do is I actually reposition the monitor. Mostly I do colonoscopies, so I keep my monitor behind me and to the left so that the cord is coming relatively easy and less strain on my body. So you want to think about that monitor. And the first thing that you notice when a young trainee comes into endoscopy, he is focusing on getting the endoscope into his hand and rushing to do the procedure without thinking about what is happening to the umbilical cord. The umbilical cord may have a coil, and he doesn't really recognize that, and he is in a rush to do the procedure. When you have a coil in the umbilical cord, that scope actually becomes heavier and a lot more resistance to move the scope, and you'll be straining a lot. So the first thing you should do is to take the coil out and straighten the scope. And by straightening the scope, it almost acts like a baton in your hand. It's very easy to move your scope, and you can actually do a lot more movement without any struggle. So now coming to the endoscopist, as you can see, there are 1, 2, 3. As you can see, there is a nice padding here. I think it is worthwhile doing that because it keeps your arches from falling and you have less strain on your joints. And I never used clogs before until a few years ago. And Selvi actually said, why don't you use clogs? You'll be easier on your feet because I started having problems in the arch of my feet. Towards the end of the day, I started having pain. But once I started using the clogs, it made a big difference. So having a proper attire makes a big difference. And also making sure you have nice, easy clothes to allow you to do a lot of different ranges of movements. And we'll talk about exercise and relaxation, but let's talk about what the endoscopist should do to prevent injuries. So here is an endoscopist, and we're talking about the posture. He's a little bit stooped forwards, and by stooping forwards, what happens is he's going to put a lot of strain on his back. And as you can see here, the patient is in the middle of the bed. I'm going to talk about this position of the patient, where the patient should be when you're doing colonoscopy. Majority of the procedures, if you look at all the endoscopies performed all over the United States or maybe the rest of the world, it is mostly colonoscopies are the maximum number. And one simple thing that you should do is ask your assistant or nurse when they position the patient to move the patient to the edge of the bed. So if the patient is at the edge of the bed, it will solve a lot of your problems. And I want to repeat that. Keep the patient at the edge of the bed and you will stay away from a lot of issues. And we're going to talk about that. So here the patient is moved to the bed. You could actually walk back and you are much more straight. So two things are important. One is the height of the bed. It should be proper height. If it is too low, you're going to stoop. And where the patient is on the bed. If the patient is in the center of the bed, you're going to lean forwards. You want to have the patient at the edge of the bed, and table should be a proper height so as to have no stooped posture. So as you can see here on the left, this is incorrect position. The patient is in the center of the bed is a little bit low. And by correcting these two things, getting the patient to the edge of the bed and increasing the height of the bed makes you automatically stand straight with ears above the shoulders, back straight, and neck and spine aligned. So you may think that this is not a big deal, but this is a big deal to prevent injuries. The other thing is, how do you stand? You know, you don't want to have your knees locked because that's going to create some stress on your body. So you want to have your knees at least flexed a little bit. This is what most athletes have in terms of how they stand in a particular posture, so that they do have less stress on their knees. So knees should be, as you can see here, there's a lot of stress here. You could avoid that by having your knees slightly bent, and the feet should be about shoulder width apart. So something to keep in mind. Coming to the elbows, elbows, if they're too low, you're going to cause some issues with your elbows, like a tennis elbow. And this could be avoided and keeping your elbows at least in the neutral position. So as you can see here, I want to go back here. I want to make this point clear. Patient is in the center of the bed. The bed is not of a good height. And all we did was move the patient to the edge of the bed and increase the height of the bed. That has corrected so many things. Your back, your angle of this one is corrected, and you will enjoy your work. These are simple things, but they make a lot of difference for you in your endoscopy every single day. Finally, I see a lot of young endoscopists, they stand very close to the bed. When you are close to the bed, you end up holding your scope very close to the bottom. And when you hold the scope very close to the bottom, the scope is actually almost like a rigid rod. And when it is a rigid rod and you want to twist, you have to apply a lot of force. And you have to apply not only a lot of force, and if you're going through a difficult movement, you have to hold that for a long period of time. So a lot of force for a long period of time, excessive movement, and for sustained period of time, you are set up for an injury, for sure. That's why when you're doing a very difficult colonoscopy, you sometimes come very close and to the bed to make those movements, and you are going to injure yourself. How do you avoid that? As you can see, you step back. By stepping back, you are holding the scope a little further away, and the moment you hold your scope a little further away, the scope actually becomes almost like a very floppy, and it is very easy to move your scope without having to apply a lot of force. By stepping back, you have another advantage. You can use your whole body to make the movement. You can use your shoulder to make the right-left movement. You can use your elbow to make a right-left movement. You can use your wrist to make a right-left movement. And then you can use your thumb or fingers to make the right-left movement. There are several areas in your body that you could use to make that movement. And this is something that you should practice to how do you achieve a right-left movement? Because up and down, there's nothing much except moving your thumb up and down. But right-left movement, if you can actually figure out a way to do the same thing using different parts of the body, that way what happens is you don't have to rely on one particular area of the body for a movement. So you can disperse it among different segments of your body so that you have less chance of getting injury. And it boils down to one simple step: stepping back from the patient, bed at the correct height, patient at the edge of the bed. And this applies for colonoscopy. And you can actually do the exams with very little stress on your body. So as you can see here, there's a difference between the two and how to use your body to talk. Finally, young people may not realize that they may be using a lot of force for strangulation, and that produces a lot of stress on body. And you want to practice almost like a pencil grip and try to be like an artist. And I've also learned that you could lessen the amount of force you use to hold a hand if you use a little bit of a gauze or a towel. And when you do that, you don't have to hold it tight. If you look at people with arthritis, they have larger handles so that they don't have to put a lot of pressure, right? So it's the same concept by using a towel or a washcloth to hold the scope, especially when you're coming back, so that you have less need for applying a lot of pressure. So we talked about how to plan, schedule, maintain scope, and reflect on yourself to make sure that you do it right. And it's also important for us to do other things to maintain our body in terms of exercise and relaxation. And at this point, I would like to open the discussion. And before I go any further, I would like to make one announcement. That is, Asmin, are you there?
Yes, I am, Dr. Arju.
Asmin, why don't you share your thoughts? I think it's important for the group to know. I want them to know what you're trying to do, and then we can open this thing for discussion.
Thank you, Dr. Arju. So this is a very opportune time for me to talk. For a while, through my training and now as an attending, I've realized that ergonomics has been important. I started doing endoscopy later in age. I was a hospitalist for many years. I was a researcher for many years. So I already came in with some aches and pains. And then after endoscopy, the aches and pains were different. So it was time to realize how to promote longevity in this profession. So I've read numerous ergonomic articles. Dr. Arju is a big proponent. Dr. Shergill is on this talk, and I've heard her talk before. And one of the things I realized is that there is a key gender difference between the way men and women scope. But I couldn't find any any actual data, we know that women would be shorter in stature. We would have smaller hands. The devices are not, they're unisex. They're designed for men and women. What I'm trying to do right now is I have started a survey which will be sent out as an email link to GI physicians across as many as we can reach, to determine if we can differentiate or find some key differences in what exactly it is that separates men and women in the way they do endoscopy, in the way they stand, in the way they hold their scopes, distances, heights, um, distance from the monitor, etc. And then if we determine those key points, we can try to target things specifically for males versus females, certain heights, certain builds, and that could be a future work in progress. And the intention of this is that there are more and more women who are coming into the field of GI. So if you look at match data from 2019, now 39% of first-year female fellows are females, first-year fellows are females. So with more women coming into GI, we probably need more devices or more training that is specific for women to promote longevity. There is also the issue that, women will have babies. There could be, pregnancy at time and doing endoscopy. All of those, if we can get more knowledge on this, then we can try to study it further and also train people better in the future, or train someone like me who's already had some injuries to see how I can do better. So I really would appreciate all of your participation in this.
Thank you, Asmin. I would like to invite Selvi, Minaz, and Amandeep to share your thoughts. So Minaz, you want to talk about microbreaks and your experience, because I've certainly learned about the term and I try to use that. I think it's a very important concept that you want to share.
Thank you, Raju. Very, very nice talk, very informative. And I just wanted to echo what Dr. Bhatt is doing, to also add to the concept of women and ergonomics, is that particularly for colonoscopies, in addition, a lot of women select women endoscopists, so keep that in mind in your survey, that endoscopy, colonoscopy in women can be a little more challenging than in men. And injury in women, ergonomic injury can be, some data shows more. So that may be something you want to look at in your survey as well. So the concept of micro breaks is very interesting. And what it really means is taking a mini break, which could be anywhere from 30 seconds to 1 or 2 minutes, every 30 minutes to every 45 minutes. The idea of this is to give muscles some break, to let lactic acid build up, clear up, to let some strain release happen. And this has been actually nicely studied, even in the surgical literature, where they looked at, because surgeries tend to be, long, many surgeries are several hours, and they did a couple of studies where they looked at surgeons who took breaks and those who didn't for the same surgery length. And they found that the concentration was better in those who took micro breaks. The factor of fatigue was less. It did not lengthen the time of surgery. And these, again, we are talking about micro breaks, a few seconds, 1 or 2 minutes every, say, hour or so. And also this kept up in center in the mind of the proceduralist, that they wanted to focus on the ergonomics aspect of it. So I think from our point of view, The goal is that the fellow not just reach the cecum, but reach the cecum safely. And we, as part of an AGA, had an ergonomic task force. I was part of that in 2016. And this is one of the things we reviewed, that Microbreaks are very helpful. In addition, I want to add that there was one study which showed that if you added to the Microbreak a mini exercise, so break plus a mini exercise, actually was found to have moderate benefit, even more than just the break. And the exercise could be micro stretching, hands, arms. So I think for an endoscopy procedures, this is particularly useful, I feel, because, a lot of endoscopy procedures, upper endoscopies are, 20, 30 minutes, colonoscopy maybe 45 minutes, an hour. And right after a procedure, you have the opportunity to take a break and also do a stretch exercise before your next case.
Thank you. Thank you. Thank you, Minaz. Amandeep.
Hi, Raju.
Thank you so much for joining. I really appreciate this. So we want to hear your thoughts, especially for a first-year fellow, what you would tell them. And for some of us who are aging, I guess. So we want to hear your thoughts. Thank you so much.
Yeah, I think you've given some great pearls to first-year fellows and for those of us who've been in practice for a while. So this is a great talk and overview of important concepts for all of us to make sure that we're practicing every time we pick up a scope. I think the main message to the first-year fellows was that this is as important as anything else you're going to learn in endoscopy. I think oftentimes we focus in on the patients and indications, contraindications, and how to make a procedure sort of safe for the patient. But there's so much time and training that goes into developing your skills that we need to make sure that we're taking that same amount of time to keep you protected. And that's where these factors come into play. And I became interested in ergonomics when I was a GI fellow, so many, many, many years ago. One of the women who was in my residency program was had joined the fellowship program 1 year ahead of me. And she was one of the smartest people that I knew. And after 1 year of fellowship in GI, she left GI and became a radiologist. And I was really concerned to hear that because, again, she's the smartest person that I knew. And I thought, like, what does she know that I don't? But you just have to pick up the scope once to know that really it wasn't developed with the endoscopist in mind. It's an amazing tool. It allows us to do amazing things, but it was not developed with the user in mind. And that's sort of a key concept in ergonomics, sort of help a job to fit a worker instead of forcing a worker to fit into a job. And that's unfortunately where we are with the scope, where we've all had to develop our own techniques in order to be able to manipulate the scope properly. So you can use very high forces when you're turning those dials, when you're holding that insertion tube. And the key is to develop techniques right now that allow you to really minimize the amount of forces that are required to manipulate the scope. So the easy things, as Dr. Raju has talked about, is making sure at the outset your room is set up so that you're setting yourself up in the most comfortable position possible, because you're only going to become more uncomfortable throughout your procedure. So taking that few seconds at the beginning of the procedure to make sure that your monitor, your bed, the patient, everything is sort of optimally positioned, as well as Dr. Raju pointed out, what your umbilical cord is doing, because the position of that umbilical cord really influences the weight of that control section on your hand. Once you get started, then it's all about trying to optimize your technique, keeping that scope sort of as soft, as short, as straight as possible. So it's maximally responsive and you're really having to use minimal force to do any kind of torque deflection. And that's a technique that you're going to learn sort of throughout the years to come. And you will hopefully master that skill set before you leave fellowship. But within those 3 years, really sort of paying attention to your body. And if after a day of endoscopy, as Dr. Raju talks about, you do have some pain, thinking about where is that pain on my hand or my forearm, and then speaking to your attendings and saying, I'm having a little bit of discomfort here. Can you watch me scope and let me know what I can do better or do differently to try and minimize that pain? So it's really just to make sure that you guys are aware and can advocate for yourself and giving you the tools to be able to do that. But it was a great overview, Dr. Raju. Thank you for sharing that with us all.
Thank you, Amandeep. Salvi.
Yes, Raju, there's a question in the chat that asks if there are specific, and maybe if Dr. Shergill and Dr. Shafi could comment, are there specific exercises or stretches that could be done both during micro breaks and as part of a daily routine that reduce injury? And Dr. David is commenting it might be an interesting collaboration with physical therapy department. And I would just add anything specific for first year female GI fellows that would help with either strength building or that type of thing.
So Amandeep, Akira is an advanced endoscopy fellow at Mount Sinai. So just want to give you a little bit of a background about Akira David, Dr. David.
So I'll let Dr. Shafi speak about the micro breaks. Just in terms of exercises, we actually had, with Dr. Raju's help, had collaborated with a Houston ballerina on our DVD, who she's an expert in gyrotechnics and was able to sort of help us create, after watching us watching Dr. Raju do an endoscopy in the endo suite, developing a series of stretches and exercises that sort of help to relieve muscle strain and redevelop core strength while you're sort of degowning after an endoscopy. And so I would encourage, if you guys have it available to you, watching that ASGE Ergonomics DVD, which does incorporate some of those exercises and stretches. The hard part is that women in general have less muscle mass than men. And as we age, our pinch and grip strength decreases. And so unfortunately, we're kind of at our prime right when we graduate fellowship, if you're in your 30s when you graduate fellowship. And then after that, our ability to generate force sort of slowly decreases over time, although the requirements of the scope and the requirements for us to, what it's required to turn the dial or to manipulate the insertion tube does not change over time. So there's, it's really difficult to advocate for doing exercises to try and increase your muscle mass just to hold the scope. I mean, what we really need to advocate for is a better scope design that allows us to utilize the scope so that even a 5th percentile female can pick up that scope, and even with her 5th percentile muscle mass, be able to manipulate that scope without developing injuries or having issues with it. So it's really a scope design issue, and there's very little that we can do, honestly, to try and overcome that, except for at the outset trying to develop the best skills and the best techniques to minimize forces while we're scoping, obviously to stay as healthy as possible. So exercise and strength training is just a part of a healthy lifestyle is important. But to specifically do exercise to try and build up muscles, we're almost never going to build up enough muscles to be able to hold that scope without significantly exerting ourselves.
Thank you, Amandeep.
There's also a comment, Raju. Dr. Srinath says that I've been using hand yoga video from Yoga by Adrian on YouTube, 11 minutes every night, and also use hand grip tools. So any comment on that? And then also, Dr. Shergill, do you, in your article, in your recent article, which I just shared a link with everyone in case they hadn't seen it, are there any accessories or devices that you use on top of your endoscope to kind of ease the injury to your body as you're doing procedures?
So there's no devices that I use personally, because when I learned scoping 15, 16 years ago, those weren't as commonly available. And so my technique is based on not utilizing those. Though when our fellows are starting out, we do introduce them to the dial adapters for the right-left dials. And actually, I know Dr. Satikno's on the call. He's been doing a lot with trainees and trying to optimize trainee scope handling. And so he's personally witnessed the difficulties trainees have in sort of, especially that reaching over and accessing that right-left dial. And I know has become more of an advocate for that dial adapter. And so perhaps we can have Dr. Satikno comment on that. And I think that your other question about other devices, we are studying something called the Pentax scope stand. So we did receive a Pentax research gift to be able to study what's essentially a scope stand that you can put the scope on, and it relieves that static load associated with holding the scope. And we think may also make it a little bit easier for us to access the dials because we're no longer having to stabilize that scope. So that's a study that we had looked at in simulated colonoscopies, and hopefully we'll be putting that for publication soon.
Dr. Satikno, would you like to comment, sir?
Yes. Hi, good morning.
Good
Can
morning.
you hear me?
Yeah.
Yes, we
Yeah.
can hear you.
I think the one of the biggest issue that we have in endoscopy today is that the part whereby a trainee learns how to manipulate the handle, the knobs, is not done optimally. It is actually quite hard for a trainee to learn how to manipulate the knobs. And we just like basically just throw them into the pool and say, start learning this. And we never really assess whether their hands are ideal, is it too small or not for the endoscope. Therefore, we actually never assess whether they would need an accessory, which is the right-left knob extender or not. So we've been doing a lot of studies to look at whether a trainee would need one or not. So if their hand is small, and a good guide for that is if they wear a small size glove, then basically they cannot reach the right and left handle. And I think as a result of that, then they turn right and left using their wrists. And Raju had talked about using the hand to the point of extreme, and that causes injury to the joint. And that's one thing that maybe somebody like Amandeep or you can start studying it. Will you change these practices if you equip people with the right size equipment? So that is something that's not known. There's also many things that are not known. I mean, if we train people well from day one, could we actually make their ergonomics better? All of these things is like Raju seems to be like including these slides, and then that many that are referenced, because all of this field is widely open. And I urge you to really study it, because this is an issue that that will come again and again.
Thank you,
I
Rob.
think another part that needs to be commented is that yes, we realize that the endoscope design is not optimal, but then the endoscope design is what we call as a dominant design, which is like eyeglasses. They are dominant. They have been used for hundreds of years, and there is really no new design that can come up except maybe the use of soft lenses. So with that, I think it is unlikely that the dominant design of the endoscope handle can change. What that means is that it doesn't mean that we shouldn't stop studying it, but maybe the strategy that we can do is that we should try to mitigate the issues. So using the right-left extender, for example, consistently is one mechanism of doing that.
So there is Aparna, you want to comment on something that you're using?
How's
Aparna?
that?
No, there's a comment from Aparna.
Yes, sir. Because I was having trouble with the darking during colonoscopies. One of my attendings had me buy one of the hand grippers that people use. I got it on Amazon. It's just one of those exercises to strengthen my hand grip strength. It's about $4, and I work on it. I do about 4 sets of about 5 exercises several times a day. And I found that I was, and also focusing on the pencil hand grip position when holding the scope. And then I found that I was doing my colonoscopies much better after I started doing that. So that was one of those things he set me to do. And that is something, again, my hand, I use the small size gloves. And so that made a huge difference when I started working with that. So it's one of those, let me see if I can, yeah, let me pull up the video and I have it here. So,
Okay.
yeah, it's this device here. And then I just work on it. I just do these and I can change the grip strength here and basically work on it several times a day. And that seems to make a difference because it works on my wrist. And I do it both hands, but typically I need it for my right hand. And I do it fairly religiously.
That's good. Aparna, where are you located?
I'm in Chattanooga, Tennessee. I'm with the University of Tennessee Chattanooga program.
Right. Thank you so much. Thank you.
Mhm.
Thank you for sharing that. I think it's very helpful.
Yes, sir. Mm-hmm.
Minaz, any
Raju.
comments on Microbreaks? Yeah.
Yes. Again, I think it's very important to incorporate that. I think the way I think of it is that in addition to what we think of accompanying for the patient, we should think of what we can do for ourselves. So when we do the procedures, as you've highlighted very nicely, I, some years ago, was asked to write an article on endoscopist preference gender-wise, and one of the reviewers asked me this question that, have you ever had injury? And I had been a gastroenterologist for 16 years and I had never once thought of injury to myself. So as we think of safety to the patient, we should also think of safety to ourselves. And Microbreaks is one way of doing it that we can control, because as has been mentioned, there are some things that we do not have direct control on, particularly in endoscopy design, the scope design, but there are things that we can control, which I think may have some impact, maybe low impact, but over time is helpful. And that is PPE, like you mentioned, and Microbreaks. So Microbreaks, again, would be for an endoscopist. I think of this that take 1 or 2 minutes after every procedure, which might be about a 40-minute length procedure. And so the exercises that, as Amandeep also mentioned on that very nice ESG video, which was made in our center, was how you can actually use some of the tools you're using in endoscopy to do exercises. So for example, the rubber gloves, when you are taking off your gloves, you sort of stretch your hand and pull with that and get a mini exercise. Or when you take your gown off, you roll it over your head and sort of stretch your arms out. And this is what you're doing in the Microbreak. And perhaps lean against the wall and push against it and stretch your back and upper arms. So again, the concept of Microbreak would be 1 or 2 minutes of these kind of exercises and between every procedure. I also, Raju, wanted to make a point that, typically we've been taught that ergonomic injuries happen after a decade, 11, 14 years of work, but actually there was a very nice survey a year ago where they interviewed first-year fellows, and something like 47% of them, first-year fellows, said that they had noted new musculoskeletal injury or pain since starting endoscopy. So early is good. Early good ergonomics is good.
Good. Thank you. Thank you. So we're going to have one last comment. I want to invite Joseph Zhang, one of my colleagues at MD Anderson. Joseph, you want to ask the comment? Maybe Roy could answer or Amandeep could answer.
Sure. Hi, good morning, everybody. Yes, actually, I as a fellow, I always thought it was interesting coming, for myself all these years, I've been interested in ergonomics at the computer station, with keyboards, mice. I probably own 10 or 20 keyboard or mice ever, and always kind of interested in how these things were designed. And when I first started fellowship, the first thing I noticed was, well, the wheels, on the dials are on a perpendicular axis on the handle, and I just, I looked at it, kind of manipulated it, and I always thought it was interesting that it was forced in this kind of configuration. I just always wondered how industry decided on the design. Do they take endoscopists, and do they take hand moldings and see kind of where configurations are? If anybody knows, I'd be very curious.
Yeah, I was struck by the design of the scope as well, and maybe Dr. Satikno knows more about the history of it, but when I've spoken to the engineers, both at Olympus and in Pentax, I don't, unfortunately, think they're that thoughtful to take into account our hand sizes or how we manipulate the scope into that scope design. So it kind of happened, and since the scope design has been released, we've sort of been stuck with it, and there hasn't been a lot of changes to that scope design. When some companies have thought about changing the scope design, and I know for a while Olympus was trying to motorize some of the scope dials, again, they haven't been very thoughtful about ways to minimize the strain, taking into account how we're using that scope. And so I think a lot of it gets to the scope has never been designed for the users. The design was just made and everyone's sort of been forced to use it. And actually physicians we're our own worst enemy. So I know Pentax for a while had developed a team to specifically look at scope redesign and trying to come up with new and different designs that really change the configuration of the scope, but sort of still tried to preserve the hand movements and the muscle memories that we've developed, just so that it wasn't so different or iterative a change that it would be unacceptable. And yet almost every single design that Pentax sort of had introduced to an endoscopist, because it was so new, because they were fumbling around and so uncomfortable using this sort of new design scope, they almost for every single design gave it negative marks. And so it was very difficult for this team to try and move a new scope design forward. And so when we've tried to disrupt the industry, I think as physicians, we think about, oh my gosh, how are we going to learn how to use this new device? And so unfortunately, industry disruptors are not given a lot of support by physicians, especially in these kinds of mini focus groups, because we can't get over how we would have to basically relearn how to scope. And so I think that as physicians, we need to develop a bit of a broader mindset as well, thinking not just about the procedures at hand, but how we can, over a long term, continue to perform these procedures. Roy, do you have any more history on how that scope design came to be?
I have been, or we have been involved with the scope design for, I would say, 15 years. And I would say that the scope design have actually evolved. One of the biggest issue now is that for every generation of endoscope, it actually takes about 10 years for the new cycle to come out. And we are just about to see some of the newer designs in the next couple years. But I must say that the scope design have been perhaps influenced too much by the male dominance in the field in the past, so that the scope had been made for bigger hands. Although I must say that since the past 10 years, there have been a significant effort to make the scope, number one, meet the smaller hands. So there have been ways that the endoscope have been so-called remolded, and a certain part of it cut so that the smaller hand can handle it better. And more recently, there have been a lot of efforts to make the scope much more lighter. I think many of the scopes, maybe 2 generations ago, were so heavy that you would get the trapezius muscles constantly aching after a few hours using it. And they actually had scope hanging holders to mitigate that. But the newer designs have been much more lighter. Is it as light as the disposable? No, not yet. But there have been efforts to do that. Now, going back to what I've said earlier, maybe it wasn't so clear, but if you if you were just given an endoscope and say, go figure out how to handle the endoscope and how you can manipulate the knobs, the tendency is actually to learn the techniques that's the easiest. And when you do that, then you depend on only the thumb finger. And when you do that in the long run, then you tend to have injury to the thumbs. So that may be what you were trying to refer to. And what we have recently found is that if you just give the trainees maybe 2 or 3 days in the beginning to learn to manipulate the up, down, and the right, left using all fingers except the little fingers, actually they will develop that technique. So that is the harder way to do it, and most programs do not yet realize that that would be a good investment. But unfortunately, there is this design that is comes from like 20 years ago that's more for bigger hands. And there is also this tendency whereby we tend to grip the control handle almost like the unideal way if we don't learn it properly.
Thank you. Yeah, I stretch what 8 or 9 keys on a piano keyboard, and I still have trouble with the small wheel with the single hand. So I always thought that was very interesting. Even for I feel like a rather relatively big hand, I still struggle at times, depending kind of on the configuration. So, but that's interesting to know. Thanks.
One last question is from Laura. Laura, you want to ask the question?
Yes, so I asked if any of you have looked into preventing any, or have you guys looked into ergonomics for techs and nurses in the unit? I know that sometimes, we handle the devices, and to me, I have to constantly like change from my right hand side to my left hand side because sometimes my hand hurts. So I was just wondering if you guys have ever looked into any ergonomics for the nurses and techs.
Amandeep, you are the best to answer this.
I think that unfortunately the field as a whole is underdeveloped, and so that's another area that's underdeveloped. I think that there's been some attention paid to for especially during insertion of the colonoscope to cecum. Sometimes physicians can ask for external compression of the abdomen in order to facilitate insertion to cecum, and so there's been some papers that have been written in the nursing journals about how to optimize giving external abdominal compression to sort of minimize the extreme postures of the hand and the forces that are used during that time. But I think that many of the same things that we talk about in terms of making sure you have a neutral posture, trying to minimize forces, just as we talk about with physicians, apply to the nurses and the technicians in the room. So when I could see that a high repetitive, potentially high force technique is going to be feeding the tools into the endoscope. And so especially if the endoscopist has asked you to help with that, that can be an area where you may have developed extreme postures while you're trying to reach the control section and then feed into the tools. And so just making sure as much as possible that you're developing and optimizing your postures and minimizing your forces is going to be important. And I know some people have talked about dipping the end of the tool into a little bit of lubricant to try and facilitate and minimize the friction as they're feeding the instrument. That's something to consider as well, but especially for something like ERCP, when everything gets very wet and when it's wet, it becomes harder to grip. There can be very high forces, I think, that are used to hold the tools and to feed the tools, and that's certainly another unmet need.
All right.
Yeah.
Thank you so much. Amandeep, thank you. Thank you, Minaz. Thank you, Selvi. Thank you, Roy, and everybody else. And I would like all of you to take a look at Asmin's request, redcap.link /endoscopy. If you could help her with a survey, I'll be grateful. And hope you all have a great weekend. Thank you so much.
Thanks, Raju. Thanks,
Thank
everyone.
you so much, Raju.
Thank you.
Appreciate it. Thank you.
Thank you, everybody.
Thank you, Raju.
Bye-bye. Thank you, sir.
Thank you.
Thank you, Dr. Arju.